Okay, thanks for joining us, everyone, for another edition of Discussions in Diagnosis. It's my privilege to welcome Dr. Sybil Marsh this morning. Sybil is Program Director of our Primary Family Medicine residency here at Cleveland Medical Center and has many years of experience and lots of expertise in identifying and treatment of opioid use disorder and other substance use disorders. And opioid use disorder is the subject of our discussion this morning. So thank you, Sybil, for joining us. I think that we're going to start, and Dr. Marsh does have a few slides to present as well, with some basics about the scope of this problem, how severe it is, and what the risk factors are for OUD, or opioid use disorder. So Sybil, if you'd like to start sharing your slides, you can go ahead. Or
Sure, I will. And just to, since I know that's one of the objectives today is to have those numbers, I think there are two numbers that are good to keep in mind. The one is that with the ways that we have to diagnose opioid use disorder, we'd say that there are about 7 million people in the United States who have an active opioid use disorder now, today, and over 100,000 people who died of an opioid overdose. There was at some point a thought that those people dying of an overdose would be new to opioids or naive to them, but it's really not the case. Those people who die of an overdose are more often someone with an opioid use disorder that hasn't been identified, or where they haven't had things click so that they could get some treatment and remove themselves from the risk of that overdose death before it happens. So those are our numbers. Let's see. I just made a couple of slides to situate us. I think there's nobody that is a healthcare provider who hasn't had some experience with a patient with opioid use disorder, whether it's diagnosed or not. But it's sometimes a little less certain as to what we're supposed to do with those people, or if there is a kind of a routine to follow, and what kind of evidence there is to support the way that we manage opioid use disorders. Let's see, I'm gonna try to hide my little meeting thing.
there you go. Mm-hmm.
And so what you'll see, I think, by these couple of slides, which incorporate some of the kind of standard practices that we use, and some of my own reflections, is that that opioid use disorder, like other substance use disorders, has diagnostic challenges that don't apply to other illnesses all the time, and I'll leave you to reflect on what those are. So most of this information is from the ASAM Essentials of Addiction Medicine, because that's a kind of a standardized reference that we would use in addiction medicine. People have been diagnosing substance use disorder for a long time. Opioid use disorder is a subset of substance use disorder, and when you look at people who have substance use disorder in the United States, it's about 1 out of 10 people has a vulnerability or an ability to develop and maintain a substance use disorder. And of those people, about 20% are people that will have an opioid use disorder over their lifetime. The availability of opioids over the past 20 years has caused fluctuations in that number, and has put us in different situations when we're thinking about how do we identify an opioid use disorder, and how do we approach it, and we'll talk about that a little bit. So here you can see, this is a description in ancient Egypt of a person who has alcohol use disorder. How do we know he's just not somebody who, like everybody else, likes to get intoxicated now and then, if it's part of their cultural pattern? Well, we can see here that he has repeated the kinds of behaviors that that the observer doesn't like. He has had consequences in a variety of spheres of life. The medical sphere, the orthopedic sphere, the social sphere, even his own friends don't want to be bothered with him anymore and would like to get rid of him. So you see the isolation, the repetition of the behaviors. And when we look at how we are now defining substance use disorders, we see that we haven't really changed very much. The way that we decide if someone has a substance use disorder is really about reports of their behavior. It's by observation of their behavior, either self-observation or observation by people who know the patient well, or observations by a professional who should know about the particular behaviors that can predict a bad outcome for that patient. So here's what SAMHSA says. Substance use disorder is said to occur when the recurrent use of alcohol and or drugs causes clinically significant impairment, including health problems, disability, and failure to meet major responsibilities at work, school, or home. And the DSM-5, which is the diagnostic tool that we would use, says that the diagnosis is based on evidence of impaired control, social impairment, risky use, and pharmacologic criteria. We'll see that as far as most substance use disorders go, and opioid use disorder, not in particular, but among them, pharmacologic criteria don't work very well. And we really still have this basis of observation of behavior to make a diagnosis. Things are coming along somewhat. In the 1990s, we decided that, well, we shouldn't just think people have this bad behavior for some reason that we don't know about. Let's try to look for some mechanisms. With the advent of PET scanning, there's been some identification of the areas of the brain that are involved when a person has a compelling, irresistible drive to use a mind and mood altering drug that's going to be harmful to them, either in the present or predictably in the future. So luckily you can PET scan the brain of a rat, which is where this original research was done, and you can find comparable structures in a human brain. So this is a kind of a very simple scheme of the reward system, the reward pathway. Where things happen the most is in the nucleus accumbens, which you can kind of popularly people call the pleasure center of the brain, where impulses and triggers and sensations go to be processed. When they get processed through this reward system in a person who doesn't have a vulnerable brain, then there are a lot of feedback mechanisms that say it's okay to have some pleasure from this pleasure-inducing substance, but not too much where I'm going to be putting myself in danger or where I'm going to have a negative consequence that I don't want. So there are all those feedback mechanisms that work. In a person with a vulnerable brain, that reward system is hyper developed and doesn't respond to feedback. That's the kind of basic mechanism that that underlies all substance use disorder. So you'll see that when we talk about opioid use disorder, it's not a unique disorder, and each substance use disorder has some features determined by the substance itself, but overall it's this phenomenon of heightened reward and decreased feedback that underlies all those disorders. So as time went on, there was more thought about, well, why do some people seem to have this mechanism and some don't? Because if we look at what are risk factors for developing a substance use disorder, one is exposure to the substance that tends to light up the reward system. There are people who are lit up by any of that group of substances. There are people who tend to prefer a particular substance, and often because there's some other co-occurring diagnosis that's a mental health diagnosis, say, that would make a person prefer a stimulant over a depressant. But the risk is having a vulnerable brain and having exposure to the substance. What makes a vulnerable brain was the next question. So this developmental definition of a substance use disorder, or this developmental postulate about what causes some people to have a substance use disorder where others don't, is the next step. So here, this is Nora Volkow, who's the has been the head of NIDA for a long time, says drug addiction develops as a progressive process. It involves complex interactions between biology and environment. And that,
on the sixth floor.
Could everyone please mute?
Yeah,
don't mute on the sixth floor there. And then the exciting piece of this is dragging the epigenome into the discussion to say that what explains this environmental and biological interaction. So the environment, things that are happening to the person, the biology, the way those things are being processed. So this is the kind of idea that we're working with now, is that substance use disorder is really a developmental disorder. It's not necessarily an inevitable happening for a person born with that ability to develop a vulnerable brain. Things could go another way in a different environmental setting, but that over early childhood, adolescence, and young adulthoods, things may happen before that brain is fully developed that are maladaptive and that produce this condition where the brain doesn't have defenses against those mind and mood altering substances. So once that cycle, once that condition is there and the person is so rewarded by their use of that chemical, which you can see that for a child living in a kind of more chaotic home, or a home where there's a parent that has a substance use disorder, those exposures might occur earlier in life. This cycle sets up of binging and intoxication and unregulated reward, a negative affect and withdrawal phase, which drives the person to want to seek their next use, and then preoccupation and anticipation of the next use. And this is a cycle that can go on for a long, long time. It takes about 20 years for a person with alcohol use disorder to get to a point where risks of continuing that cycle outweigh benefits, and they end up in treatment. As far as opioid use disorder goes, it has been dependent on the source of the opioids as to when those consequences accrue. So all of those years when we were taught in family medicine, we really need to think about pain as the fifth vital sign. We need to eradicate it. We all had those buttons that had pain with the big red circle and the slash through them. Patients with an opioid use disorder could maintain their disorder without having a lot of legal consequences, and being able to hide some of the negative things that were happening behind the rationale that they were being medically treated. Once those prescribed opioids went away because of threats to prescribers, that they were going to need to change their practices, and some very legitimate misuse of those medications by prescribers to allow those people with vulnerability to opioid use disorder to get access to medications without any kind of assessment or screening. Once that went away and people with opioid use disorder turned to other sources of opioids, we would now see that it's a much shorter course from a person's beginning use of opioids. They'll travel through whatever kind of prescription things are available, where they feel like they can have some control, to what used to be heroin but is now fentanyl. People often will start by using fentanyl nasally and then switch to injection. And the consequences of that use often will rack up much more quickly than they used to. So when risks of continuing the use outweigh the benefits of the use, which is that feeling of reward with binging and intoxication, that's when people often will self-seek treatment. What causes those risks to outweigh benefits? Well, with opioids, opioids and alcohol do share a kind of a common feature, and that is the developments of tolerance and withdrawal. Those are tolerance means you have to try to get more to get the effect that you were used to, and that means a lot of money or criminal activity. Withdrawal is very unpleasant. People feel like they are going to die and that they want to die when they're in withdrawal. So avoidance of that becomes exhausting. And then the consequences can be legal, familial consequences, health consequences, and so on. That's what they said in AA in 1940, and they're not wrong, that addiction leads to jails, institution, and death.
So, Sybil, just something I've always been curious about, and what is the effect of opiates? What is is it a high that's similar to cocaine or some sort of stimulant, or is it a state of relaxation? And I've actually even asked patients this, and they're not really able to tell me why they pursue opioids.
Yeah, but when you think about where the reward system starts in the brain, it's really buried in one of those kind of lower parts in the brain stem and in the midbrain. And often people don't have access through the cortex, where they do the thinking and reasoning, to what's going on in those parts of the brain. So while we used to think, well, people would seek a particular substance because of its effect, we know that all those substances have a similar effect on the reward system. The way the reward system gets stimulated might produce different behaviors, so that when someone uses an opioid, they are more likely to be depressed, nodding, and sleeping. When someone's using a stimulant, they'll be up and active. And then the common pathway is, once that sort of behavioral phase is over, then they're in that reward zone. And that's really what they're looking for. It can be confusing because we could think, well, the person is self-medicating. They're trying to create a particular, relaxation or stimulation for themselves because of another problem that they have. But really, it's all the same pathway.
Okay, so let's talk about diagnosis, which is the focus of this series. So tell us a little bit about how we would pick this up.
Yeah, so 3 diagnostic strategies. Most people diagnose by self-diagnosis. And, when it comes to screening and assessment, it plays such a minor role compared to other addictions where the substance is legal and the trajectory is slower. So while we have a lot of formal screening and assessment for, say, alcohol use disorder, because people might not know that they have a disorder, they're not using normally. People with opioid use disorder, generally, now that legal opioids aren't available, know that they're using opioids in an abnormal way. And the issue is more like how long can I continue using in the same way, versus getting into trouble. So most people are self-diagnosing, and the idea with helping people to do that is to help them to reduce the harms of their use and to introduce them to the idea of treatment. There are screening and assessment tools that I'll just flip through so that we can get some discussion. And, just to note that all the pharmacologic, physical exam, and biochemical findings that you think might be helpful they're not specific. And even though you might find these disorders in people with opioid use disorder, they don't define a disorder. Overdose is not diagnostic, but, it's strongly suggestive because we know that overdoses tend to occur in those people that have been longtime users. So like for other substance use disorders, we can start with a validated single question screen. And if the screen is negative, we don't need to go further. There is a more detailed screening tool, that's the DAS-10, that gets the person to reflect on consequences of their use, and you could score that up, and it gives some, it's a validated instrument that gives predicts pretty well people that have a disorder versus have had some aberrant use or some hazardous use but don't have a disorder. This is our diagnostic tool. It's a DSM-5 criteria. You see how generic it is, because the idea is that opioid use disorder doesn't have features that are really different from other use disorders. And 11 items is a lot, but there's just 3 concepts here. It's loss of control, repeated use despite negative outcomes, and then physiologic complications. That's the tolerance and withdrawal, which is a little different for opioids and alcohol and benzodiazepines from other drugs. There are attempts to predict and to prevent the development of a disorder, and that's really where the current interest is focused. Residents will be familiar with the opioid risk tool because it's part of our assessment for patients who have a prescribed opioid. Unfortunately, it's not very sensitive or specific, and isn't a great tool. I find it stigmatizing to use with patients, but it is supposed to give an indication of if a person is more or less likely to develop an opioid use disorder. There's a lot of interest in identifying adverse childhood experiences, because people with multiple adverse childhood experiences are more likely to develop a substance use disorder and other mental illnesses as they age and go through their developmental stages. The genogram is really helpful to identify intergenerational and familial patterns. And then, the quest is for a kind of genetic study that would identify people at risk for developing a substance use disorder and intervene with them early. Here's our limitations. They still depend on observation and self-disclosure a lot. And even though they're validated internationally and cross-culturally, all of the instruments that I've shown you, they do depend on the assessor to make some adjustments for the context that they're in. There's that transactional thing that can cause the person being screened to want to please you and to conceal consequences and the extent of their drug use. And the assessor can always appear as judgmental, even if they're trying not to be. So that are some limitations. What to do about opioid use disorder: harm reduction, support a person's motivation for change and their ability to self-diagnose, provide resources, and every person with an opioid use disorder should be referred for pharmacologic treatment with psychosocial supports. If there are medications involved, it can be very confusing for you and the patient. So we want to plan a non-punitive response that doesn't require a patient to necessarily self-diagnose with an opioid use disorder. And there are ways to change that use of prescribed medications so that it's safer for that person. And with that, I will hit the escape. And so those are the sort of tools that we have. And what are your, what are your thoughts or your experiences?
Yeah, thank you for all that great information, Dr. Marsh. I think that the bottom line is I think the patient has to be willing to disclose this and has to have some interest in seeking help and in acknowledging that they have a problem. I've had patients who I'm certain have opioid use disorder, will even, screen positive, but have no interest at all in treatment as well. And I guess it's similar to anything else, such as tobacco cessation or alcohol abstinence. You've just got to kind of work with them over time to make them realize this is a problem. Has that been your experience as well?
That's that concept of harm reduction, that the person might not be ready to acknowledge they have a problem or that they need to do something about it, but that we can still help them even without that self-diagnosis. So that's where all of those interventions come in, like testing your drugs to see if there's fentanyl in there, needle exchanges, and all of that kind of thing is what helps that person to be able to stay safe while they're deciding if the benefits of using are outweighing the risks.
Okay. All right. I think we can open this up to any questions or comments from our group. I'll give folks a few more seconds. Looks like we're good. Sybil, thank you so much. And thanks to everyone for joining us this morning. And we hope to see you all next week for another discussion in diagnosis. Have a great day.